Glad to have you today,
Yeah, hey
sir.
guys. So I'm Andrew Winge. What do I do? I'm board certified physician in family medicine, emergency medicine, but I, over the years, have had a really, really strong interest in men's health, longevity, testosterone, and hormonal optimization that started basically with, I think a lot of guys start off like I do with some of their own medical issues in that area, and then they see the results and they see the benefits of optimizing hormones.
For sure.
And when I did, whenever something like that happens to me, I get very interested in it. I have to know everything about it. And so I started TRT now, probably, gosh, it's about 13, maybe almost 14 years ago now. I've kind of lost track, but that caused me to take as deep a dive as I could into the role of hormones and health. And then obviously, I have a big interest in longevity too, and cardiovascular disease and cancer prevention. And that's all from my family medicine background. So I got to I've like integrated those two things into my current men's health
Sure.
practice. Because as you know, I mean, none of us in our formal medical training, I don't know how much hormone training you had, but outside of insulin and like a little bit of thyroid education
Just
as a family
TSH.
doc, nothing, right? We don't get
Yeah.
anything. I got no lectures on testosterone therapy whatsoever, other than the occasional like passing comment that it was dangerous and caused prostate cancer.
Sure. Yep.
So I trained in the late 90s, so we definitely thought that was the case then. So yeah, no training. So, you had to go out and you have to pursue this stuff on your own. Thankfully now there's good CME courses and things like that. But yeah, it's same as in the NP world. It's no different than the MD world. We come
Sure.
into practice basically clueless about this sort of stuff. And a lot of times with a lot of like misconceptions and baggage that we have to get rid of. And I had to do that too. I thought I was going to get prostate cancer if I started testosterone.
Oh yeah.
We all probably did. So.
That or like heart attacks. They always say you're
Heart
gonna have a heart
attacks,
attack
yeah, and
or a
that was
stroke.
one for sure. Yeah, and in fact, I in early on had fellow colleagues be like, "Bro, you're gonna have a heart attack," and I was like, "Well, maybe they're right. Maybe I am gonna have a heart attack." And of course, you look into it further, and you realize like not only is it not associated with heart disease, but it actually is beneficial, from a
Hmm.
cardiovascular standpoint. So many things in medicine, they say like half the stuff we learned is wrong. We just don't know which half until later. So. That was definitely
So
in that category.
how long do you think, or have you been able to quote unquote persuade or actually educate some of your peers, or are they still stuck in that antiquated mindset?
I my outside of my men's health practice right now, I'm a full-time emergency medicine doc. I'm double boarded. So in the emergency medicine world, it just doesn't come up very often, other than, we see
Sure.
the occasional guy that comes in with an elevated hematocrit that I see the other docs kind of freak out about it. And most of them don't know why it's elevated. And this happened to, gosh, probably that was about 6 months ago. He came in with like a cellulitis in his foot, so wasn't even anything like related to TRT, but the guy's hematocrit was like 53, 54. So they called
Freaked out.
hematology because they thought he had polycythemia vera or some other big issue. And I was like, guys, this is just from testosterone. So it's nothing to worry about. And I couldn't talk them off the ledge. Like they were just like hyper focused on this elevated hematocrit. So it doesn't come up very much in my day-to-day emergency medicine practice, but when it does, I still hear the same myths that we've all heard before. And mainly it's cardiovascular disease and DVT, PE, stroke, that sort of thing. So I kind of leave it alone. I pick my battles in the emergency department. What I have noticed though, I will say, and this is kind of nice because I've been in practice now over 20 years. Um, I'll use like in the cardiology world, for example. So I talk to a lot of cardiologists, obviously from the emergency department, because we see a lot of cardiovascular disease and heart attacks and whatnot. The older generation cardiologists were like universally opposed to testosterone. It was
Oh,
just
absolutely.
you're gonna get a heart attack. It wrecks your lipids, blah blah blah. Now, at least with these newer guys that are relatively new out of fellowship, that we have a cardiology group where probably half the docs there are, they've probably been out of fellowship less than 5 years, and they're really good and they're really smart. They're at the very least they're neutral about it. Like
Yeah, yeah,
they're not they don't immediately blame the testosterone for whatever the problem is. They're at least, they know that it's at the best it's neutral. They don't sing its praises. They don't start testosterone on their patients, even though I think
sure.
many cases they should. They're at least neutral about it. So I do see like the paradigm is changing a little bit. The urologists for sure, like all the new younger urologists
Oh yeah,
understand. I think there's still, I think, some holdouts in the old, the old school guys that maybe are still worried about prostate cancer, but yeah, the younger urologists, I don't work with them as much as I do with the cardiologists, but they seem to understand it pretty well. But the primary care world, like internal medicine docs, family med docs, still just a lot of ignorance. It's not
they
part of their,
hate it, man. They
they
hate it.
hate it. They don't understand it, and they don't really want to understand it in many cases, which is kind of strange to me. You'd think something that's this popular and this prevalent, like you think you'd want to be on top of it, but they shy away from it. I know I'm sure you've seen it too.
Absolutely,
Um, but
absolutely. Do you
I don't
think
tell people that I'm on testosterone anymore. Yeah,
because
they
you don't
they can
you
probably
don't have to
figure it
explain
out.
yourself?
Yeah, I just don't want to. I'm just kind of tired of having that conversation with my
Sure.
peers. With peers that I like these guys, but they're ignorant. They don't know anything about it. So I just don't talk about it.
Yeah, man. It's another damn business anyway. It's
Correct. Yeah. If they ask, absolutely. I'm happy to talk about it because testosterone radically changed my life. It really, and it changed the course of my career. And so, yeah, I'm obviously very pro testosterone.
sure, sure, sure.
Yeah.
What so symptomatically, what was it that you're experiencing experiencing that led you to pursue
Yeah,
taking body
yeah.
weight?
I mean, pretty classic. My story is not unique at all. I started on TRT around 38 years old, and I had probably, thinking back, I was probably hypogonadal for 3 to 4 years before that. And it was like with all men, kind of a gradual, just sort of onset of these non-specific symptoms that kind of crept up on me. I had finished my ER residency. So, obviously when you're a resident, I mean, I was exhausted all the time.
Oh yeah,
But that was because of my workload. But it didn't get like I didn't get better when I was out as a staff doc and I was getting a good night's sleep and I was able to be healthy and start exercising. Fatigue is a big one. Probably the biggest thing and the thing that got better the fastest for me was brain fog.
that's
And I know that's a
man right
super
there.
common effect. And I tell guys like I was a competitive and non-competitive powerlifter for like over 10 years. I had already built a substantial amount of muscle tissue. So when I got on TRT, there were not major body composition benefits. I think there have been over the years now, um, in that I've been able to maintain, but I didn't put
Preservation
on a
for
ton of
sure.
muscle tissue because I was already 240 pounds, but the benefits were all above the neck and they were
Yeah,
they were dramatic. So, for example, like, night shifts are rough. We're super busy and um so the night shifts got a little bit easier. I wasn't making like these little mistakes sometimes where the nurses would have to say like, "Hey, did you really mean to order this?" So little errors like that like went away. Um I just got a lot nicer, and I'm generally a pretty like friendly, gregarious guy, but um, guys with low testosterone, you get a little, sometimes these guys get a little bitchy, and
they're
I
cranky,
did
man. They
too.
are cranky.
I was a cranky little bitch at times, and that's just not my personality. So I felt like I could deal. The emergency department is an extremely stressful environment, and you really have to be able to keep your cool when things are going sideways. And it was much easier to do that once I got on testosterone, and it happened for me fairly quickly. So all of these symptoms, so the fatigue, my libido was like non-existent prior to it, and it was causing like major relationship issues for me. But it was mainly like work performance, my personality,
Sure.
cognition, that sort of stuff was really starting to slip. And I was really trying. I was eating really well. I was exercising. I was doing jujitsu. Like I was
Yeah.
doing all the stuff that we're supposed to do. I did not have excess body fat. Um, So in my case, I actually had in full disclosure, I had a medical condition that led to my low testosterone. So I had bilateral cryptorchidism. So for you guys
Correct.
that don't know what that is, I was born with bilateral undescended testes. So little embryology lesson: the testicles develop up around as a fetus, they develop around your kidneys and your adrenal glands, and then shortly prior to birth, they descend down into the
To go
pelvis.
down.
Exactly, and then they're supposed to, boop, right before you're born, they end up in the scrotum, and they do that, to maintain a slightly lower body temperature, which is what is
Hmm.
necessary for sperm production, et cetera.
Sure. Yeah.
Anyway, long story short, I wasn't born in the United States. They missed
Oh,
it.
interesting.
Yeah, I was born in Barcelona in the early 70s, and I don't know if they just missed it or standards were different then, but nowadays, if a kid is born with that condition, they surgically repair those like lickety split,
Like
usually
instantly.
within 6 months. Yeah, so I was like 3.5 or 4 when they finally repaired it.
Gotcha.
So I knew I would have fertility issues, but I was always told that, and I learned in medical school that I would, but testosterone wouldn't be a problem for me. And I assumed they were correct because, like, I made it through puberty. I was an athlete. I put on a lot of muscle tissue in the gym. So I'm assuming I had normal testosterone levels like through my 20s and maybe into my early 30s. But we know now that, men with cryptorchidism, not only do they have issues with their Sertoli cells, but they have issues with their Leydig cells too. So again, at some point, maybe in my mid 30s, they just kind of shut down. And so I had primary hypogonadism. And so that was the issue. And of course, when you have primary, the only solution is TRT.
Yeah.
Yeah. Yeah. So anyway, that's kind of in a nutshell my story. I felt better. It was probably placebo, but honestly, within the first week, I felt like that brain fog just started to clear. My mood improved, and then it's just been smooth sailing ever since. And it really, again, I said it before, but it like radically changed the course of my life. I know it's not for everybody, and I don't want to sound like a salesman, but it really, like, I'm where I am right now because of testosterone.
Yeah. Man, that's
And
awesome.
when you come across something like that and you're a medical provider, it's only natural, I think, to want to share that with patients and have other men have the same experience, which is one of the best parts of my practice, is I get to help guys who are even worse off than I was fix all those problems.
Yeah.
So
Yeah. How's your approach to hypogonadism management? How's that evolved since you've got, because even the guidelines, I mean, the
yeah,
guidelines are so outdated. So
they're
how
so
did you
outdated.
approach then versus now? Like,
Yeah, good
how's your approach
question.
been?
Well, I mean, I think like a lot of us, when I initially did some of my training, I did some of the things that we know now we probably should not have been doing, like controlling estrogen.
Hmm.
So yeah, I used to,
I used to be guilty of it too, man, 10
we're
years
all
ago.
prescribed, anastrozole, and we thought that that was the right thing to do, and measured serum, estrogen levels, and then had very strict hematocrit cutoffs, because there was, we thought that, elevated hematocrit from TRT, so called secondary erythrocytosis, we didn't want people to have strokes and heart attacks. And so, just like all things in medicine, I mean, my emergency medicine practice has evolved over 20 years as we get new data, and the same thing with my men's health and hormone practice. So, I used to do once a week injections for my guys because that's what I was trained to do.
Yeah.
And granted, that is still better than the every 2 weeks that
Every 2 to 4 weeks.
urologists and endocrinologists were doing at the time. So, at the time it was an improvement, but now I rarely recommend that for guys. And so it's evolved in that way as well. I think I have a much better understanding, having gone through infertility as well, like how to help men stay fertile. I really didn't have
Hmm.
much insight into that when, certainly before TRT and in the early part of my career. And so I have a much better handle on that now. Especially, again, my wife and I, we went through IVF, but I was able to improve my count significantly while remaining on TRT, with not just HCG, but recombinant FSH and
Hmm.
a few other things like that. So I think I just have a better overall understanding of just how important testosterone is. I always, everybody knows it's important for sexual function and muscle tissue, and I think that's kind of obvious, but I don't think I fully appreciated how important it is for the brain, for
Hmm.
cognition, and especially the cardiovascular system. Like I had no idea how it could help people with heart failure.
Oh
It
yeah.
can be amazing for people with heart failure. Um, and a lot of people would assume that it would actually be dangerous for people with heart failure, but there's good data that shows it can help with that in certain cases.
Hmm.
It helps with type 2 diabetes. Like it should be a mainstay, I think, for many men with type 2 diabetes and insulin
Oh yeah.
resistant obesity. So, yeah, I think I've just got a better appreciation for just how important that hormone is. And then the spinoffs from that is also how important the metabolites of testosterone are, like estradiol and DHT.
Hmm.
I had no idea. I had no appreciate. Estradiol was a female hormone. Like, why would I even care about that? That's what I used to think, obviously. But now, I mean, I have a much. I take estradiol, so for my heart. So
Yeah.
I obviously have changed my tune a little bit on that too, and I do not prescribe anastrozole anymore. And I try to steer guys away from drugs like finasteride if possible.
Sure.
That's an uphill battle sometimes, you
I
know.
mean, uh, by
It is what
nature,
it
we're
is.
vain creatures, man. Some
I
vain
know, I get
creatures.
it. I get it. And I understand. I mean, clearly I'm a DHT victim here. But and I understand that when I noticed that my hair was thinning too, it hit me pretty hard. But it is what it is.
I mean,
I
almost all. I'm 40. I'm lucky, but I know at
Yeah,
some point it's going. It's going, and I'm just
it'll
embracing
go
it.
to a certain extent. Yeah.
Mhm.
And
It's part of life.
genetics, it's genetic. There's a big genetic component to
You
it, and
can't
you
beat
roll the
genetics.
dice and you get what you get. You can't change your parents. So
No,
um
so
yeah.
I'm curious, like with the estradiol, the 17 beta estradiol talk and all that.
Mhm.
How's your knowledge evolved from that? Because again, like you just admitted, I too used to believe, man, it's a woman's hormone. It's gonna make you
Absolutely.
grow tits. It's gonna make you look
Yeah.
like a pussy. It's gonna make you cry.
Mhm.
So
Mhm.
how's that evolved in your practice?
Well, I went from one extreme of having to control it, and specifically like keep it in this tight, narrow range where we used to think it had to be, between 20 and 35, and hear different numbers and things like that. And that was quote optimal. To now, again, now I'm kind of on the other end of it where I mean, I don't even really check it. I have patients that they want to know what their numbers are, and I don't mind ordering that test for them, but we have a little chat about it. Like, listen, this test, this number that we're going to get on this piece of paper is not really clinically relevant to what's going on. And we're going to try not to make clinical decisions based off of this number. And these are the problems with blocking estrogen, because most of my guys have come to me from other clinics.
Sure.
I actually don't, I mean, I do start guys on testosterone, but most of them are already on testosterone. And the reason that they come to me is that they're not doing well on their current protocol, or they've got like other medical issues that are just not being managed well. So, diabetes, et cetera. So, so anyway, I try to educate guys about it now. And, how I got to where I am now is a lot of it is just study. I took, I highly recommend Neil Rousier's courses.
World Link.
I took those a number of years ago. His from World Link Medical, I think is the name of his company, and he has a four-part, like really intensive series. And I like evidence-based medicine. I'm a research geek. And so what I really appreciated about that is his course and some of the other ones that are out there is, the data's out there. You just have to look at the papers, you read it, and you're like, okay, I mean, I've been doing this wrong. And it's,
Sure.
none of us like to admit that we were doing something wrong, or admit honestly that maybe we were harming our patients by doing this. But the data is the data, and it is what it is. And so, you should adjust your practice based on new evidence. And that's what I did. The evidence came out. I used to think one thing, but the evidence became overwhelming to me that I needed to change my practice, and that I needed to not do these things to estradiol that I was doing. And so I changed my practice. And
Yeah.
it's good you don't want to ever be like emotionally tied to a protocol. Like, there are guys on the internet, they get angry, they like literally have an emotional
Absolutely.
response when you bring this subject. I mean, you've seen it. And that's just like, why would, that's kind of silly to me. Like, why would you have an emotional response? If I've always thought if somebody who knows more about something shows me that I'm wrong, like I'm thankful to them.
Yeah,
Thank
it's
you
very
for correcting
liberating.
me. Yeah, I appreciate it. Thank you. And so yeah, that's basically what happened is I read voraciously. I take every course I can find, and I talk to people who are smarter than me about this stuff, and I learn as I go. And I don't ever claim to be an expert in anything. I'm a perpetual white belt, but I try to learn something new every day and evolve my practice that way. So
Yeah, I mean that's the only way. It is a very liberating feeling when
it totally is.
you, as long as you can admit that you embrace mistakes. I mean it's just part of life.
Absolutely. Yeah.
I do think a lot of, at least from what I've seen, I'm sure you've been in the game for a long time, but a lot of people that have been practicing for extended period, they become very dogmatic.
Oh
I've
yeah.
seen a lot of providers get to the point they don't even learn anymore. They just kind of,
No.
if that's the way it's done, so that's the way we'll do
Right.
it. That's
Yeah, and
unfortunately.
they don't want to hear anything that contradicts their, this sacred cow that they have. And estradiol in our little world of men's health, like estradiol is definitely one of those like sacred cows that they just don't want to hear it. And they'll come up, they have arguments why they're correct. But at the end of the day, I mean, I think if you weigh the evidence, like the evidence just doesn't support what we used to do, which is, prescribing AIs and trying to like tightly regulate estradiol and whatnot. It just doesn't, it's not supported by the literature. And again, I didn't really appreciate how important estradiol was for cardiovascular health because that's my little niche that I am interested in. And I should have known in hindsight, but I guess I just didn't appreciate it as much as I do now. So, heart disease is the number one worldwide killer of men and women.
Mhm.
So why on earth would I want to do anything to increase your risk? And theoretically, trying to modulate estrogen the way that we do it could increase somebody's risk. So I don't want to do that.
Sure. And
Uh,
for the anti or the crowd that always wants to block it,
yeah,
they always say the same hackneyed things. They always say,
yeah,
"Well, he's
yeah.
emotional," or "He's a
Correct.
gyno," and they don't realize gyno is still
Right.
manipulated by progesterone, IGF-1,
It's a right.
DHEA, testosterone, multiple factors.
Yeah, 100%. Yeah, so yeah, many of these like and this gets talked about a lot on Stephen Devos's YouTube channel, which I highly recommend, obviously. Um yeah, low or these high estrogen symptoms are not the root cause is not usually not high estrogen. It's something else. It's something
Yeah,
else. Insulin resistance, chronic inflammation, obesity, sometimes psychological stuff, obviously. Uh, you
that's
know,
what I see the most is like obesity or
obesity
a
is
fatty
the
liver.
yeah. Hmm. Obesity honestly is not to get off on too much of a tangent, but like that is the root especially visceral body fat is like the root cause of so many chronic medical conditions.
Hmm.
Type 2 diabetes, hypertension, cancer, heart disease. Like if we could just find a way to cure visceral adiposity or visceral body fat issues, I mean, it would like transform this country overnight.
Absolutely.
Yeah, it's crazy. it's kind of it's a joke, but it's actually not funny. I say in the emergency room, the only reason I'm in business is because of meth and Mountain Dew.
Huh.
So, Mountain Dew meaning like all the sugar and crap that people eat.
Sure.
Because you know, whatever it might be in the general population, my emergency room population, the obesity rates are like 90% plus of the people that I see in the community that I serve. And it starts like I see obese 3-year-olds coming in.
That's terrifying
It's
and
terrifying.
horrible.
It's absolutely terrifying. And it plays a role like in our talk today, like about testosterone, because like these kids that are coming in, morbidly obese at age 3, like I saw a 200-pound 8-year-old, not that long ago. Like that young man, like he'll never have a normal testosterone level
He's gonna have
unless
mosh,
ever.
mosh
Like,
syndrome.
yeah, he's mosh, right?
Hmm.
So like he'll go through puberty having never experienced the high normal androgen levels that a teenager should have that help develop his brain.
Hmm.
So what comes out on the other end of that as a 30-year-old is a little bit frightening. Like, what is that? There's actually this is the stuff that like I think about at night. Like, this has a big implication on society when you
Sure.
have an entire, like maybe two generations deep now of hypogonadal young men that are supposed to be going into like the most productive years of their lives, 30s, 40s, etc., having like never had a T level over 400.
Yeah.
Um, I- that could be a big problem. Could be a
Would
big
you,
problem.
so what would you suspect or predict that avatar of an adult would look like?
I mean, I think they look like a lot of the folks that I see in the emergency department. So, I mean, I see a lot of 300-pound plus guys in their early 40s that are coming in with their first heart attacks.
Mm,
Guys that are coming in as undiagnosed diabetics. So just last week, I had a guy that came in and said, "I'm not really feeling. I'm just not feeling good." It was his chief complaint, and just did a quick blood sugar on him. It was like 450, and he had no idea that he was a type 2 diabetic. He probably
he's
had
probably
been
been cruising like that for
years.
years.
He had no idea. He had no idea. And so as an emergency room doctor, I should not be the first person to diagnose your type 2 diabetes. But the fact of the matter is that I diagnose that probably like 4 or 5 times a month in the emergency department. And it's in guys who, this guy had been overweight since he was a teenager. His diet was terrible. Obviously, he didn't exercise. And honestly, like a lot of my population still smokes too. So he had a lot of like unhealthy behaviors. But the end result of that is this guy now has, major, major medical issues in his early 40s. And honestly, like it's going to take him out of the workforce. Just to look at this like from an economic standpoint,
Sure.
again,
That's
your
interesting.
40s is when you're the most productive as a man, usually. Women too these days, but men, especially economically productive in your 40s, usually at the peak of your career, like you're paying taxes, you're putting back in. And then maybe
Yep.
when you're in your 70s is when you start drawing on the medical system. So what we're seeing now and what I see every day is guys in their sometimes late 30s, early 40s who are on disability now for like these for complications from type 2 diabetes, obesity, heart disease. So they're not working. They're not putting back into the system economically. And so like not to mention like the issues with the impact on their family and their quality of life, but just like looking at it from a number standpoint, these guys, the economic productivity is just boom, just going way down. And these guys are now draining the system, or they're drawing large sums of healthcare dollars starting in their 40s when you're normally like my dad's 90.
Damn,
He
good for
didn't
him.
start having medical issues till much later in life, and he was super productive up until his early 60s. Basically, he ran a law practice until his 60s.
He's a badass.
But these guys, like, they start pulling out of the system in their early 40s when they should be putting in. And how many more generations of that can we have before the whole thing just comes
Or we have
crumbling
some kind of
down? I don't
societal
know.
collapse.
Societal
Find
collapse, yeah. Um, I work with residents and med students, and I kind of jokingly say, but again, it's not a joke. Like I say, welcome to the ER. Like it's a front row seat to the collapse of the U.S. healthcare system.
damn, that's a good
This is
phrase.
it. It is a front row seat. So it's it's a little frightening.
It is,
I
man.
love my job, and I like what I do, but I it's my personality type to kind of think long term and what are the downstream implications of you know having like the guy we just talked about, that avatar. What do we do when we have 50 million of him or 100 million of him in this country, which we probably do actually at this point.
Not
I
and
don't
not to
know.
mention
It's a
the
little frightening. It's a little
like there's
frightening.
less physicians coming out, man. Less
Oh,
less and less
absolutely.
physicians,
Yeah,
less
huge.
providers.
There's not going to be enough NPs either, because to fill that gap. The medical students that I work with come from one particular school for the most part, and their tuition's like well over it's approaching $60,000 a year. So they come out with substantial debt. And so if you want to be rural family medicine doc, which God knows we need more of those,
Yeah.
you're not going to make big money and you may never pay off those loans. So these kids are all like, I ask them what they want to do. They're like, I want to be an anesthesiologist. I want to
Derm.
derm. Yeah. They're going into these high paid specialties. And a lot of it is like, I just need to get my loans paid off.
You can't blame them, man. Like, why
It's
go
a
to
disaster.
pediatrics or nephrology if you're not going to,
Well, yeah,
make 200 a
exactly.
year?
Yeah. So there's a lot of problems in this country with our healthcare system. And I just, it's like, I tell everybody, like, you have got to get healthy because you don't want to get sucked into this system as much issues as we're having now. I'm like, just wait 10 years or 20 years. It's going to be a disaster. And so ideally, like you start taking care of yourself as soon as possible. You avoid all these problems that your peers are having. It's been really interesting. Like I'm going to be 51 in September, and I have multiple good friends that have had bypasses and stents and are on 7 or 8 different prescription drugs, and it just kind of blows my mind. And I'm just like sailing right along, no problem. And
Yeah,
but that's because I take care of myself. I have some medical issues that are mainly, I have some genetic issues with cholesterol, but I
sure.
manage those as best as I can. But like if you just do what everybody else does in America and eat the standard American diet, don't exercise, and all the stuff that we see, man, it's like you're gonna get sucked into that system. And once you're in, it's got you. And it's not good.
No,
So
it's not.
no-
I don't know how it is there in Oregon. Like, say here, we have what's known as 10 care,
mm.
and that's our government
Oh
type
yeah.
of assistance.
Yeah, we
Those
have the same
people,
thing.
so the ones here, they're allotted up to 5 medications that
Mm.
they'll be paid. That's it. I mean, that's it.
Mm. Yeah.
If you're relying on the government to take care of you, they're not going to take care of you. It just
No.
is what it is.
Oh no. Yeah, you're in big trouble. You're in serious trouble if you're expecting the government or your doctor to take care of you. Like there was a guy, this always stuck in my head. This was a couple years ago. I had a guy that the ambulance was brought him in and he had an infected toe. He was a diabetic guy and he had a Slurpee in his hand, like while he was on, and they were moving him out of the gurney. He had a big, full sugar soda. And in the course of me talking to him, he's like, yeah, my doctor just can't get a handle on my blood sugars. And I'm just like,
It's not his
it's not your
responsibility.
doctor's job to get it. Like, there's a reason he can't get a handle on your blood sugars, buddy. It's what you're doing. Like, you can't get a handle on your blood sugars. Your doctor's probably doing the best he can, but you're drinking, 64 ounces of pure sugar soda every day.
Sure.
And you wonder why your blood sugars are out of control. So I tell people it's not even your doctor's responsibility to take care of to get your doctor's not job is not to make you healthy. It's your job.
Yeah.
Your
Yeah.
doctor's job is to help you when you're sick, because that's what we're trained to do. Um, I'm not, I didn't get conventionally trained to help optimize people's health. I know how to do it now, but in med school, I'm sure it's the same for you. You learn how to take care of diabetes and kidney disease and heart failure and blood
Yeah.
pressure. Nobody tells you how to optimize people, which is so that's on you. Like as a patient, like you've got to seek that out. That's how I
It's
feel
on.
about it.
Yeah, the onus is on them, but I
It
think,
is.
like you said,
Yeah,
I think they've been trained that, at least from the patient standpoint, patients have been conditioned to think, they just wait till something happens, go,
exactly.
and with nothing on
Exactly.
their end, no
Yep.
skin in the game.
No skin in the game. And I don't want to be too hard on people because I get it. Like sometimes you just don't want to think about stuff like that. It's easier to put your head in the sand, but you can't do that, especially over the age of 40. But what I see in my community is that's kind of when, at least in women too, but I would say men, the wheels start coming off if in their 40s. That's
Hmm.
when these like major issues like first start rearing their heads. But the fact is, like the things that led to those issues, they were probably just getting started in their late 20s or early 30s. They were there, but they were just ignored. The
Sure.
blood pressure started creeping up and body fat started going up. But they wouldn't they sort of look at their friends and be like, well, I'm still doing better than Bob over there. So, I don't need to go to the doctor. I don't need to look into this stuff until there's an issue, and then
Oh,
that's too late. Then sometimes Now you're in.
Yeah, and that's one thing I noticed with guys. Like, we we're known to wait till shit hits the fan, and then we want
Yeah.
you to bail us out real
Yeah,
quick.
absolutely. Yeah, yeah. That's a male thing. I mean, not gonna lie, I'm kind of,
I've been there too, man.
I've done stuff like that myself over the years, but um, I don't know. It's in the if you're in the medical field, I think it just kind of gets rubbed in your face a little bit more, what the consequences are of this sort of
Sure.
stuff. And so, maybe we're just more aware of it than other people.
So where
So
do you think, or where do you think healthcare is headed towards, or what kind of change, or what needs to happen to improve healthcare, or where do you see it being? What is the
that's
optimal form
that's a
of
great question.
healthcare access?
Yeah, that's a great question. I mean, I don't have the answers, obviously, to fix this system. I honestly, I don't see it turning around at this point. There are the basics of supply and demand, and healthcare is something that has a limited supply. But what I have seen over the last 20 years is the demand just shooting up. People are just, it's like every generation is less healthy than the one before, and we're at a point now, and this was actually made the mainstream news about how the current generation of kids is going to live their life expectancy will be less than their parents, and it was attributed to obesity. So despite all these like really expensive medical interventions and bypasses and all these fancy new pharmaceuticals, people will life expectancy is going down in this country.
Hmm,
So that's excuse me, that's a big problem. And so there's going to be some tough decisions in this country that will need to be made. You can't have, you know, 15 aircraft carrier battle groups that, cost $100 billion, and you can't be giving $80 billion to Ukraine
no,
and
hell no.
having a world-class healthcare system. Which is what is going to need to happen to service all of these like chronically ill people. So there needs to be a decision there. And
Sure,
quite frankly, I think the government will probably choose to not uh, put the money into making the population healthier and providing care. They're going to be more interested in, you know, playing these geopolitical games like we're doing now. I just I don't have a lot of faith in the government solving
hell no. I don't.
any problem, honestly, and especially healthcare. So it's going to come down to the individual. And I
Sure.
hate to say it, I don't. I'm generally a pretty optimistic guy, but I don't see things going well. I think, um, we the the magnitude of the problem, like we're heading towards a state where like 50% plus of the US population is going to be diabetic. We're already pretty close to that, and it's going up. So there aren't enough dialysis centers for all these people. Like, what are we going to do for these people's, whose kidneys start to fail, which is a common complication of diabetes? Like,
Hmm.
they're going to die. They're not going to be enough dialysis centers. There's not going to be enough nephrologists to take care of these people. I mean, I'm already running into that problem now in the emergency department with people, they come into the ER and they've missed their dialysis session, and I'm calling around and I cannot find a center to take them. And I'm like, this person will die if they don't get
Sure.
dialysis. And they're like, sorry, we're full. So I'm having to pull these extraordinary measures to try to like keep their potassium in check temporarily until I can find a dialysis center to take them. So, fast forward 10 or 20 years when we have, say, 70% of the population's type 2, we got it's not going to be good.
Be shit out of luck for a lot of
You're
people
going to
in
be
your
shit out of
position.
luck. Exactly. Um, I would not want to be, and I don't want to be an elderly person in this country in the next 30 years. Unless you're fabulously wealthy, like the top 5% will always do well, right? They're
Sure.
gonna, the Nancy Pelosi's of the world will always have world-class healthcare. But the rest of us, even me as a doctor, like I'm worried about it. Um, I'm worried about what's going to happen to me, when I'm
Yeah.
80. So again, my goal is to be I want to need the system as little as possible, other than just for like healthcare maintenance stuff and just basic stuff like that. And of course, like accidents, trauma. If I get in a car accident, that is one thing we do really well in this country, not to bash the medical system too much, but like we're really good at acute like trauma care and like, if
Orthopedics and
you
all
get
that. Yeah.
critically ill or injured, we're all over that. We're all over that.
Oh yeah.
But the rest of it, we're just terrible at. We're terrible at it.
Yeah.
So,
And cosmetics, we're great at that too. I
oh,
mean,
absolutely. Yeah. Oh, yeah.
yeah,
Absolutely.
the hottest 80-year-old ever. You know what I mean?
You got it. Yeah. Botox, filler, man, whatever you want. We're totally good at that. But keeping you off of dialysis, for example, where maybe we're not as good as we should be at that.
Sure.
So, but that's, to kind of circle back, that's why it's so important to, you know, when you look at your overall health, one of the most important things you can do to stay out of the medical system is keep hormones optimized.
Yeah.
I mean, that's like one of the cornerstones of doing this. And, I see so many, it makes me so mad every time I see an elderly person come in with a hip fracture from a fall, because, that's usually from osteoporosis, which is
Sure.
entirely preventable.
Hmm.
And usually that's, if the fall doesn't kill them, it's the complications, 6 months down the road from
Yeah.
that hip fracture that are gonna, kill that person. They get pneumonia, they get
Pneumonia.
blood clot,
Yep.
whatever. And so those things are preventable. And and hormones play a big role in all that stuff. They're just if I had it my way, if I was in charge of like training doctors and NPs and everybody in the United States, like I would make bioidentical hormone replacement like a really like an important part of the curriculum, is like a
Sure.
cornerstone of treating men and women, because if it's so important, it makes such a huge difference in if not maybe like entirely preventing some of these problems, like certainly pushing them way down the road into somebody's elderly years, as opposed to like in their 40s
Yeah.
when things are happening now. So, but again, there's hormone phobia in the general medical world, at least for certain things.
You think that's going to
um
go away anytime soon, or
I don't
I?
know. Again, I do see things getting like slightly better. These trials that are like the Traverse trial that came out that,
Mhm.
showed that TRT, in high risk people didn't seem to, cause any major cardiovascular benefits or cardiovascular complications. I mean, we need a lot more of that, but it's going to take like many, many more years of that to like chip away at this. But it's hard because the endocrine society and the urological associations these are conservative, like fossilized, maybe that's not the right term, but they're slow to change, right?
Sure.
They don't it takes a long time and even once they change, then it takes sometimes like another 5 to 10 years for it to like percolate into the general medical community. So it's going to be a while. It's going to be a
Yeah.
while. So there will always be a place for guys like us, at least for the foreseeable future,
Yeah. Because I
that
mean,
that
think
kind
about
of understand this stuff.
like even the Morgenthaler trials. That's been around 20
Yeah.
years.
Been
20
forever. He
years,
he's been around
and
forever. I mean, he's the
they
OG.
still talk about it.
They still and people still don't know about it. I was just
Mhm.
talking to
Almost.
a guy he's a pulmonologist about it, and he had prostate cancer and he had no idea that yeah, you could give testosterone to men with prostate
Yeah.
cancer. But we've
That was
known
came
that
out
for
in the early
decades.
2000s.
Right, exactly. Exactly. Yeah.
So I mean, I'm
It's
guessing maybe at least 20 years till it becomes more normalized for hormone
it'll be
therapies.
a while. It'll be a
So like
while.
so your practice, you do offer, you do hormone replacement. You said you do health optimization. So what are some other things that y'all do?
Yeah. So I kind of joke. I say I lure these guys in with testosterone, and then I use that opportunity to address blood pressure, address lipids, metabolic health is a big one. So yeah, I mean, I'm really ultimately a lot of that stuff comes down to body composition, right?
Sure.
Like if you get yourself down to 12 to 15% body fat, for example, so many of these medical issues will fix themselves. And so I try to help guys kind of do that in a rational way. And, not everybody can get to 12 to 15% body fat. I get that, but every little bit helps. So I spend a lot of time with diet, exercise, and again,
Hmm.
with the goal of body composition changing. And obviously testosterone has a huge role to play in that. And so that's what I focus on. Lipids are a big one for me. Um, lipids aren't the only thing that I focus on, obviously, in terms of cardiovascular disease, but it's important. So I will try to optimize guys' lipids based on their risk factors. Blood pressure is huge. Endothelial health in
Hmm.
general. So upregulate, all these. There's a lot of things we can do to upregulate nitric oxide, and even like low dose tadalafil, certain
Yeah.
supplements, ACEs and ARBs. So there's a lot of things like that that I will throw into the mix. But the fundamentals are the fundamentals, which is, a healthy diet. I think the most evidence out there leans towards a Mediterranean style diet, but
Hmm.
again, the best diet is the one that guys can stick
You
to.
can stick with,
So I
sure.
will steer guys in those directions as much as possible. So yeah, it's a bit more, it's kind of a 10,000 foot view of somebody's health. I don't just focus in on TRT. Like, there's some windmill clinics out there. That's all they look at. And that's okay as long as you have somebody else who's looking over at your other health parameters. But yeah, I'm interested in kind of the overall health of the individual, and testosterone and hormones are a big part of that. But it's there's the three big cogs, which is nutrition, training, and hormones. Like,
Yeah,
if you get those three right, I've probably done like 95% of what I need to do to get you, as healthy as possible, and help you live as long as you can. Ideally, like for me, I want to live with the highest possible quality of life until I get to my mid 80s, 90s, maybe a little bit later, and then just boop, and
and
then
then
just
just say, all
fall
right,
off
I'll
and then
just go
just
to
say,
sleep.
see you later, guys. And then yeah, and then just, but what I see obviously in the emergency department is, again, starting at age 40 these days, maybe mid 40s, it's this gradual decline with, like, a precipitous drop from a medical emergency, and then we kind of get you back a little bit, but the vector is like straight down. So
Sure.
the last 10 years of somebody's life are like miserable.
Yeah,
Now, I don't want to spend the last 10 years of my life like in and out of the hospital, and attached to a dialysis machine. I want to be going out on a cruise, playing with my
sure.
grandkids. So that's the I try to take like a 40 to 50-year view, and I try to get my patients, if they're not already thinking that way, um to think that way. It's they want abs, and you know what? I want you to have abs too. I want you to be jacked and tanned, whatever whatever we want to call it. However, I do also want you to think about where you're going to be in 30 years, and what do you want to be able to do in 30 years and 40 years, that you're doing now. So let's work towards that.
Sure. When you when you treat patients, do you ever use like nutraceuticals? Do you use like anti-aging therapies like metformin, GLP-1s, methylene
Yeah, on a
blues,
case
stuff
by
like
case
that?
basis. Yeah, absolutely. So those there's a lot of, like, I'm not a huge, I don't throw a ton of supplements at guys. Again, if there's a small kind of core group of supplements that have good evidence that I think most men should be on. I mean, they're all kind of no-brainers. Vitamin D,
Mhm.
magnesium, creatine, omega 3s. We can throw in a few others, as well. So those are kind of a mainstay. I have guys that want to experiment with all sorts of other supplements, and as long as I don't think it's harmful, I'm not opposed to them doing that. But you can spend a lot of money on supplements and
Yeah, yeah.
end up just kind of wasting your time. Again, if you're not doing the three pillars correctly, the supplements you're not gonna get
They're not
much
gonna,
out of that
no.
anyway, right? So there's some core things that I like. Metformin's really interesting. I'm less bullish on metformin than I was, but I still think it has a role. I really want to see what some of these upcoming trials show. I mean, we've known for a long time, obviously, that in type 2 diabetics, there's some potential, like, longevity benefits, maybe anti-cancer properties, et cetera. The
Hmm.
big question is, like, does that translate into benefits for guys like us? I still kind of think yes. Like, I'm cautiously optimistic about it. So I still take metformin. I take a little 500 milligram extended release tablet once a day. I'm kind of hedging my bets on it. I have
It ain't
not
gonna
had any.
hurt.
What's that?
It ain't gonna hurt. I mean,
It's
worst case
probably not
scenario,
going to hurt, right?
you have
I mean, there's
diarrhea. So
studies
what?
about like exercise tolerance and endurance and stuff like that. I can't say that I've noticed any difficulty in my training or difficulty putting on muscle tissue and things like that. People talk about that. I think Peter T has made mention of it. But I think metformin is something to be considered. It's not frontline anymore for me. But again, if some of these new trials come out and they show that there's benefit, then I'll change my tune on it. I think rapamycin has a lot of potential.
Yep, yep.
Very interested in
Rapamycin
rapamycin. I take rapamycin at a 6 milligram dose once a week.
once a week.
The animal data is really good. Obviously, I would love to see more human data. There's data that it can reverse atherosclerosis, which I'm very
Hmm.
interested in. So yeah, so I think rapamycin is up there. Again, it's not out of the gate. I don't start guys on that, but if they're interested in it, we talk about it, and we weigh the pros and cons. And yeah, I would definitely consider that because I think it's extraordinarily safe from everything I've seen especially at these anti-aging doses that we use, which are totally different than the immune suppressing doses that I used to write for like my kidney transplant patients and stuff. It's like
Sure.
totally different. So stuff like that. Um, other things I'm not quite so sure about, things like NMN and those sorts of things. I don't consider myself an expert in those. In fact, that's an area that I need to probably read up on a little bit more. I think from what I've read, those things like that have potential. Um, but I try to be I'm a bit of a minimalist with a lot of
Sure.
that stuff.
I don't blame
Um,
you. Yeah.
and I like evidence. I really want to see
Yeah.
some good studies. And it's hard because like not many big institutions are interested in studying this stuff. So we're never going to have like millions of dollars from NIH to look into that. So it's
Yeah. Yeah.
I wish we did, but
It'll have to be like individually funded because I mean,
yeah.
again,
Mhm.
the people that fund these studies they have an outcome to make, and that's a drug to
Exactly.
market.
Yeah, exactly. Yeah.
So,
GLP-1s I think are good drugs. I mean,
oh
again,
yeah.
on a case by case basis, they're not used properly, I think, by most clinics. And I think they're like over prescribed probably. But in the right person who's on a proper weight loss protocol where they're not sacrificing muscle tissue,
Hmm.
they're resistance training, they've upped their protein to compensate. Yeah, I've seen those drugs work wonders. I haven't seen a lot of the issues with gastroparesis and stuff like that, but I have a colleague that works in the emergency department, and in his population, there's a lot of med spas and stuff apparently around his emergency room, and he sees a lot of people coming in with gastroparesis, vomiting issues. So yeah, you do have to be careful with those drugs, and like everything, I mean, I'm all about like minimum effective dose,
Okay.
whatever
Yeah.
gives you a little bit of help to help you lose weight. But I have like family members calling me like, "Hey, can you write me for some Ozempic?" I'm like,
Hell no.
"No,
Oh,
get out of here."
you're I ain't gonna write that
Yeah,
for you.
yeah,
No, no. I watched your Nandrolone video. I'm kind of curious, like, how's your
yeah,
experience been with that?
yeah. Nandrolone. Again, I was not super optimistic about it because I mean I had heard from the gym bros, obviously, like we all have, that it helps with joint pain. Okay, great. But when you look in the literature, like you have to dive in kind of deep because it's nobody's studying this anymore, but there's a lot of older studies
Hmm.
showing effect. Like it works, for pain from osteoarthritis, pain from osteoporosis, osteopenia, that sort of stuff. And I got a lot of wear and tear on my body over the years from my sports career, from being in the military, et cetera. So yeah, I went ahead and I tried it at 100 milligrams a week. It was like remarkably effective. At least a 50% plus reduction in pain,
Yeah.
especially in the shoulders. My understanding is that probably due to increased receptors and maybe an affinity with the receptors, upper extremity effects, especially like in the rotator cuff area, seem to be the areas that benefit the most from nandrolone. I could be mistaken about that, but for me anyway, that made a huge difference. So then I backed it down to 50 a while ago, and the effect is still there. And so I'll probably go down to 25 to see
Yeah,
if I can get an effect. Nandrolone, it should, for the record, I don't think it should be part of a routine part of anybody's TRT protocol.
sure,
It's not a longevity drug. In fact, if it's used excessively, I mean, there's a lot of data that it can actually be harmful. So I'm on the lookout, obviously, for any potential cardiovascular downsides to it. I haven't yet to see any. I am going to get an echo at some point this summer. I've been meaning to do that. My dad has aortic stenosis, and so
gotcha.
I want to that he developed at a young age. So I'm just kind of curious. So yeah, I mean, the second I see anything that could compromise my longevity, obviously I would discontinue that stuff. But it has really made a difference in terms of like limiting the amount of NSAIDs that I have to take. There's a lot of problems with NSAIDs, obviously.
Sure.
And again, there's probably selection bias for me working in the emergency department, but I see so many problems with NSAIDs with older people with kidney issues and
Hmm.
bleeding ulcers. And like I still remember as an intern, like 25 years ago, I killed I didn't kill him, thank God, but I nearly did with Feldine, which is an old school NSAID. And he came in asking for a refill on this stuff. This old man, he was like 75. And I didn't know any better. I was a 27-year-old intern, and I've been on this for 30 years. So I just refilled it for him. And he was in the ICU the next week, like needed a massive transfusion from a bleeding like duodenal ulcer. And it was from NSAID. So, and I see
Sure.
that a lot. So I don't know. I'm just a little cautious with NSAIDs. I don't like to take them, but I was having to take them a lot, and I don't anymore. So
That's awesome,
I
man.
think there's a place for it. I really do. I honestly, I think in mainstream medicine, like elderly people with severe rheumatoid arthritis,
Yep. Hmm.
like some of these inflammatory arthritis patients, I bet they would be great candidates. I don't have any personal experience in those populations, but um, I mean, if I had the choice between oxycodone 3 times a day or nandrolone 25 milligrams a week or 50 milligrams a week, I know which one I would take.
Sure.
You know what I mean?
I mean,
But
I've used
surprise,
it.
but as you know, what is the medical community? They're happy to write you for your oxycodone,
Sure.
your fentanyl patches, no problem. But if you write a nandrolone prescription, all sorts of red flags go up.
Man, I've used it in people with like fibromyalgia
Oh yeah,
or
right. Yeah.
people
Yep.
with chronic pain syndrome. And yeah, like you said,
Hmm.
man, um, I don't know why, man, but we've been conditioned historically that,
Yeah.
hey, take a perk, take a Lord tab,
Oh, it's crazy.
take a Norco
Yeah.
instead of this.
I get my health care at the VA, and I don't mean my intent is not to bash the
Oh,
VA because they've been good to me, but yeah, I mean, I hear this all the time from my military buddies and colleagues and even patients that go there is, yeah, they're more than happy to hand out pain medications and antidepressants. But when you start talking hormones, they just forget it, you know,
plays over.
they just glaze over or they freak out, or just like, hell no. So just, there's definitely a hormone phobia. Like it is a real thing in the mainstream medical world. It's a shame. Hormones are really useful. They're totally underutilized in my opinion for all kinds of like mainstream medical conditions. We're dealing obviously with TRT and health optimization, but there's so
Yeah.
many of these like bread and butter medical conditions that you and I saw all the time in our training that can benefit from hormones.
That we could
So many.
mitigate. Yep.
Absolutely. And they're like they're safer than these prescription drugs that we hand out like candy.
Yeah.
So
Yeah.
drives me crazy.
Well, I got one more last question. You've been here for an hour, so I appreciate your time, man.
Hey, of course.
Um, when it comes to dialing people's hormones, people's blood work, um, what is your philosophy on the actual blood work lab ranges versus their translation of symptomology?
Yeah. Yeah, good. Yeah, great question. So, I mean, obviously symptoms trump lab numbers, in my opinion. But we do live in the real world. We do, have to be concerned about third parties, occasional
CYAs, sure.
CYA, things like that. So, when I have a standard stock answer when a guy asks me like what should my testosterone level be? And my answer is it should be whatever you need it to be to resolve your hypogonadal symptoms. and
Sure.
it's going to be highly variable. And quite frankly, there are a population of men that probably need supraphysiologic levels in some cases to resolve those symptoms. I know, like Dr. Keith Nichols has talked about that. Neil Rouzier talks about it. A lot of other guys that have been doing this stuff for a long time, that they understand that sometimes you do occasionally need to push the dose. That's obviously not universal. There's some men that do worse with
Hmm.
super physiologic levels or even high normal levels. So I think of it as like every man there's a symptom threshold. And I don't know what that number is when the guy comes and sees me, but I just want you above that symptom threshold, whatever that number is. If it's 500 total T, okay, so be it. Let's keep you above that so you feel good, so that I want all your other health parameters to be as good as they possibly can be. And then that's going to be your number. Now, if you tell me like I only feel good when I'm on 600 milligrams of
Yeah,
cypionate a
you're full of
week,
shit.
yeah, then like we're gonna have to talk about that a little bit. And like maybe there's something else going on. But yeah, in general, I check the labs, obviously look at them, but
Sure.
it's the dose is whatever the dose is. And that shouldn't, like, that sounds like controversial maybe to somebody who's not familiar in this field, but it really shouldn't be. We routinely in the regular medical world use super physiologic doses of insulin, for example.
Hmm.
So why do we do that? Well, because this person has insulin resistance, they need super physiologic doses of Lantus or regular insulin, Humalog, whatever, in order to overcome their resistance. Well, some people, their androgen resistance is a thing. So maybe you need more androgen to overcome your androgen resistance. The psychiatrists do this with thyroid hormone, like to potentiate the effects of SSRIs. They use super physiologic doses of T4 and T3.
Hmm.
They'll take a guy's TSH, who's someone who's profoundly depressed, and make their TSH zero. And they do
Hmm.
that to get a clinical effect, which is to help this person who's having severe psychiatric issues and is at risk for killing themselves. Same thing, like if you have a thyroid cancer, you are going to have super physiologic thyroid hormone given to you by an endocrinologist to suppress your TSH. So it's like we do it in other areas, and it's no different with androgens. There's a case to be made for some guys needing more. So
Yeah. I think a
having
lot of
said
us
that,
do.
I don't know. I have luck with, you know, almost all my guys are kind of in that upper quartile for the most part,
Yeah.
and they
Yeah.
and they do great. But I have some outliers. So
Yeah. What's your point was like, or like what you just said, some people feel better when it's higher. Some people feel better when it's not. I mean, I've been as high as 1700. I feel like
yeah,
shit.
yeah,
I've been as low as 700. I don't feel nothing. So
right,
me,
right,
I cruise probably around 1,000, 1,100-ish at any given day. That's
yeah.
where I feel
And
the
you
best
can't
at.
tell by looking at somebody. I don't know what level you're going to need. We'll figure it out together, right? As we move forward. Um, you know, I don't get it. I get it right out of the gate, like probably 60% of the time, maybe 70% of the time. And then
Mhm.
we adjust as time goes on. And maybe as you age, things change as you age, and there's some adjustments that need to be made too. But I'm not afraid of super physiologic testosterone levels, as long
Yeah.
as, because I'm not afraid of them because I'm monitoring you. I'm seeing, hey, you know what, your blood pressure is just as good as it always was. Your lipids are just as good as it always. You're feeling better. You're not having any sort of emotional lability. You're not having any adverse effects. You're not holding water. Like, what's the problem? If there's no problem, I'm okay with it. If there's a
Yeah.
problem, I don't care what your dose is. There's a problem, and we're going to fix it.
Yeah. Okay.
So
Last one. I promise. I promise. I enjoyed just shooting the shit with people.
I,
So
I'm here all day, man. I don't have a patient till 3 o'clock.
I ain't trying to eat your free day off. Do you prefer cream versus injection by chance? Because I'm getting a lot more people inquire
It's a
about the
great question.
cream, which I'm not opposed to either one, but I'm just kind of curious what your thoughts on one versus the other are.
So I'll start with myself. I have never tried cream.
Sure.
I'm really curious to try it, but the fact of the matter is, I've done so well on my current protocol. Like I haven't changed my protocol in years, and I continue to feel so good that it
Yeah.
would just be like as an experiment just to see. Like I,
Sure.
I, I personally know, but my patients love it. Let's put it this way. I've never had a man that I've switched to cream ever want to go back to injections. Like they've all
Interesting.
done really, really well on it. So, the only, as you know, like there's pros and cons to all the delivery methods. There are guys where compliance is an issue because you have to use it. Cream goes
Hmm.
on every day, often twice a day. Um, and it can be a little tedious and sometimes guys forget. So, you tailor the delivery method to the patient and their needs, that sort of thing. But having just in general, overwhelmingly positive reviews from my patients. And I hear the same thing from other docs too, that their patients do extremely well with cream. So yeah, the standard like 20% Versabase, Lipoderm cream, whatever the case may be. Um, I'm a big fan of that. I think it works really well. I don't have personal experience with it.
Yeah.
I probably should try it at some point. I like what I like. I've
Yeah.
stayed on
Yeah.
my injections.
Like why screw with something if it's working for you,
Yeah,
you know?
but just to say it, just to have that experience, I think I should probably switch over to it. But I think it's a great way to go. And obviously,
Yeah.
like a lot of guys on Steven's channel, a lot of the docs there I know are very pro cream for a good reason. So
I mean, it works. I mean, at the
it
end of the
totally
day,
works.
the
Absolutely.
right patient works
Yeah.
great.
Yeah. Yeah.
Awesome, man.
Do
Awesome.
you
Awesome.
use it yourself? Do you take cream?
I've been on injections
Oh,
only for
okay.
eight-ish, 7 years now, give or
Okay.
take.
Yeah. So you're like me. Yeah.
Yeah, and my dose has been the same pretty
Yep.
much the entire
Me
time. So
too.
I'm just like, why throw a kink
Me
into it?
too. Yeah. But
Excellent, man.
a lot of the docs that that traveled in our same circles are very much proponents of the cream, and there's a reason for that. It's good stuff. It's
Yeah,
good
yeah.
stuff. Yeah.
Excellent. Hey,
Yeah.
Dr. Andrew Winge,
Yeah.
correct?
Yeah.
Right on. I appreciate you joining us today.
Yeah. Thanks so much for having me. It's great to finally connect. Like I've been watching you on YouTube for years. So it's great that we finally got to meet up, at least
um,
virtually.
yeah, yeah. Hopefully we'll catch it cross the paths in
One of
person
these days.
sometime.
One of these days. Yeah, absolutely.
So how can people get a hold of you? What's your website? What's your email, or
Yeah,
how
so
can people grab
my
you?
practice is called Man Medicine, and I have a YouTube channel of the same name. And so yeah, manmedicine.com. You can reach out to me. I can accept patients currently in 4 states. So
Awesome. Hell
we
yeah.
have Oregon, Utah, Texas, and Florida. There may be some additional states down the road, but as we were talking about offline, it's medical licensure is very expensive and cumbersome in the US. So it takes a lot to get a medical license in another state. But currently, I can accept patients in those states. I do, however, do coaching and consultation work for guys in all 50 states and actually all around the world. It's
Yeah,
one of the most enjoyable things I do in my practice is, talk to guys from other countries and who don't have access to, they may have access to hormones, but they don't have access to knowledgeable physicians and they just need a little bit of advice. So I'm
sure.
able to do consultations, for those guys. And again, I really enjoy that. So yeah, if you need some help with your protocol, if you want me just a second set of eyes, or just want to ask some questions that you're having trouble finding answers to, I'll do my best to help you out with that.
Excellent, man. Well, I appreciate it, man.
Yeah. Yeah.
Hey,
Thank you.
thanks for joining us today.
Yeah, absolutely. Take care.